I presented an abstract about the safety and efficacy of a CD37 targeting antibody-drug conjugate called Naratuximab Emtansine. We'll just say NARA for short, which was given in combination with Rituximab in diffuse large B-cell lymphoma predominantly, but also early on in other non-Hodgkin's B-cell lymphomas. And this was a phase 2 study. So as you know, people who have relapsed refractory non-Hodgkin's lymphoma, particularly those who've got relapsed or refractory disease who are not candidates for potentially curative therapy with either high-dose chemotherapy and autologous stem cell rescue or CAR T, have a very poor prognosis. And it clearly, this is a high unmet need where we need additional therapies. Certainly we've gotten some additional therapies in that high unmet need group in the past few years. The first one was Polatuzumab, vedotin, that was given in combination with Bendamustine Rituxan, which is, certainly an option in that patient population. And since then, we've also gotten, approval of Tafasitamab with Lenalidomide. We got Selinexor, and then the latest to join is Naratuximab tesirine. Some of these target CD79 or CD19, or Selinexor is, an inhibitor of selective nuclear export. But other therapeutic targets are required. So Naratuximab actually targets CD37. So this is a B-cell marker that has near ubiquitous expression in a variety of B-cell NHL. Around 90% of diffuse large B-cell lymphoma, for example, will have CD37 expression. So Naratuximab Emtansine is an antibody-drug conjugate that has a humanized anti-CD37 antibody, and it's conjugated to a cytotoxic antitubulin payload called DM1. So a few years back, there was actually a phase 1 monotherapy study that demonstrated that this anti-CD37 ADC is actually very well tolerated, but, response rates were modest. They had a 13% overall response rate in all patients with relapsed refractory NHL, and about 1 in 5 responded with relapsed refractory DLBCL. But what they actually found was that if you co-administer this anti-CD37 ADC with an anti-CD20 like Rituximab, this leads to actually more internalization of this cell surface marker CD37. And as you can imagine, if you're giving an ADC and you're getting more internalization, that will actually lead to more delivery of payload in your target cancer cells. So this actually led to this phase 2 study, which actually had 2 parts. So part 1 was like a safety run-in and a run-in expansion. And in part 1, they actually allowed for various different histologies. I mean, there was DLBCL, but they also included marginal zone, mantle cell, as well as follicular lymphoma. And then part 2 only included diffuse large B-cell lymphoma. So folks eligible for this study had to have prior treated non-Hodgkin's lymphoma. In part 1, like I mentioned, they had other histologies. So it could be DLBCL, but they also included follicular, mantle cell, marginal zone. And in part 2, they actually had to have relapsed refractory DLBCL and not be candidates for potentially curative therapy with high-dose chemotherapy and autologous stem cell rescue. Now, unlike some other studies in that patient population, they actually also allowed for features of the disease that would be considered high risk, like double or triple hit histology. So, translocations in c-MYC, BCL2, BCL6. They allowed for bulky disease. They allowed for transformed lymphoma. They even allowed for primary refractory disease or people who are refractory to their last treatment. And, what they found was that this was actually a very safe therapy. So not a lot of grade 3 or 4 events outside of hematologic events. So, some myelosuppression, including neutropenia, leukopenia, lymphopenia. But again, very manageable and not, much in the way of non-hematologic AEs. And when you took a look at the efficacy, overall, it was close to a 1 in 2 response rate. The overall response rate was 44.7%. But what's impressive is 2/3 of the responders actually achieved a complete remission. So remember, your response rate is your composite of your PRs or better. But of the responders, 2/3 of them achieved a CR. And also impressive is that durability of the response. So the duration of response, now keep in mind, the data is not yet mature, But with a median follow-up of a little bit over 19 months, the median duration of response was not yet reached. So, and the same is actually also true in the other non-Hodgkin's lymphoma histology. So in relapsed refractory FL, for example, they do have a longer follow-up period. The median duration of follow-up for the responders is about 22 months. And again, the median duration of response was not yet reached. We also did an analysis in terms of health-related quality of life. So there was a health-related quality of life questionnaire. And what we found was that the treatment was actually associated with a significant increase in well-being. Remember, the only two good reasons to treat somebody for anything in medicine is, number one, if you can make them live longer, and number two, if you can make them feel better. So using this health-related quality of life questionnaire, we were able to see that the majority of people actually felt better and had an improvement in quality of life compared to those folks who were not treated. And we even asked a question like, are you bothered by side effects of treatment? And the vast majority of patients said that they were not at all bothered, or, at worst, bothered very little. So we concluded that this treatment was very well tolerated and certainly led to an improvement in quality of life. So if we take a look at everything that was presented, we can conclude that the safety profile of Nara plus Rituximab was very tolerable and manageable, and most of the AEs were hematologic. This combination of Nara with Rituximab, due to the ability to get more payload into the cell, resulted in an overall response rate of 44.7%, with 2/3 of those being CRs, and obviously the rest being PRs. The median duration of response was not yet reached, so these responses were durable. And again, an improvement in the quality of life. So I think what we're most excited about is, given the efficacy and tolerability profile, this could lend itself to being a very good combination with some of our other anti-lymphoma modalities, especially in people who are, not quite as robust and not currently candidates for any type of treatments that would lead to potential cure. So very exciting time. I mean, again, we've had so many new therapies in the treatment of diffuse large B-cell lymphoma, and this is one that can certainly augment the responses that we're seeing, in combination with either cytotoxics or, even with some of our new targeted therapies. So thanks a lot for listening.